So now that we've gone through sort of all the clinical data that we can, base our decisions on treatment, we have a treatment-naive patient. We've done the OCT, we've done the fluorescein, we've done all the imaging. We now are ready to treat the patient. Dave, walk me through sort of how you decide what to treat the patient with, and what do you discuss with the patient?
Sure. First of all, I show them the OCT. I show them hopefully a normal OCT in their other eye, or one without a lot of fluid, and I show them all this awful fluid and thickness, and that's why they can't see. And then I tell them that we're going to need shots in the eyes to help this process. I say we always start with 3 shots, and we generally use Lucentis or Eylea, unless there's insurance issues that tell us we need to use Avastin, and then we do that. At 3 shot, and at the very beginning, I let them know that 3 shots is the minimum, and then we see how you do. And that a certain small amount of patients get by with only that, but 70 to 80% of patients need ongoing therapy up to monthly for the rest of their life. Because what you don't want them to do is to think that it's a 2-shot and done thing, and then they get all disappointed every time you give them a shot, which is every month for the rest of their life.
Does everybody start with the on-label drugs, or does anybody start with Avastin?
So I start the majority of patients with Avastin, and I'm upfront, even with the patients, that the reason I start with Avastin is solely a cost issue. If cost was not an issue at all, and I don't mean necessary for the individual patient, because most of my patients have insurance and a supplemental, so they're covered, but just as an overall cost issue, we start most on Avastin. We tell them it's off-label. We tell them that, in fact, the CAT study and other studies have shown that the drugs are similar, but that there are patients for whom Avastin may not be quite as good, and we have a very low threshold for switching them. Most patients, I think, accept that, and they're willing to go that way. If cost was not an issue, I would use Avastin quite rarely, because I do think that the compilation of the data suggests that while they're all good, there are advantages to Lucentis and now Eylea over Avastin, and I would use that rarely. But in Massachusetts, we've actually received letters from insurers telling us that they've reviewed the results of CAT, that their experts have determined that the drugs are equivalent, and they're asking us to use Avastin.
So I would just say that I follow Dave's approach because we don't have those issues in Texas regarding insurance companies, and I believe the data when it shows that Eylea and Lucentis dry up retinas better than Avastin, and I'm of the school that a dry retina is a happy retina, and if I can get that more effectively, which I know the data does support with Eylea or Lucentis, I end up picking one of those 2 drugs as my starting point if there's no copay insurance issues. If there's a copay insurance issue, then obviously I go to Avastin.
So Jeff, do you use PFO that's made for veterinary use that you can get for $5 a bottle, or do you use PFO in the OR that's $500?
So I was waiting for that argument. and so the reality of it is that Avastin does an excellent job in a lot of patients. And I think you're able to gauge that very quickly. And I think you're able to determine, is a patient going to have the typical strong anti-VEGF response that I like? And I have a very low threshold for moving them off. So unlike, if you read the PAT survey for 2012, I think it's still at around 70% use primarily Avastin. Well, I start probably 80% on Avastin, but overall my Avastin numbers are probably closer to 50 because I move them off so quickly. So if they don't have the response, I switch them quickly.
I think if it wasn't for the compounding pharmacy issue, I would be absolutely fine with that. The compounding pharmacy issue, basically I tell patients you got 2 drugs that have been approved by the FDA for what you have and are made to go in the eye, and one that's not approved to go in the eye and is not made to go in the eye. One's a heck of a lot cheaper. If your insurance company will pay for the one that's made to go in the eye, I feel more comfortable with it from a pure safety, not getting into endophthalmitis rate. From an efficacy standpoint, I absolutely agree with what you're saying. I think 50 to 70% of patients do great with monthly Avastin. And from a pure cost of all society, that should be a step edit where you give Avastin and then switch to the expensive drugs. However, until such a time when you can get it in a form that's as safe from an endophthalmitis standpoint predominantly, I think in a patient that has good insurance, you are putting them at risk where you don't have to.
And I think that I fall somewhere between what Jeff and Carl are saying, because we do have insurance issues and the patients have insurance issues. So I do tend to start with Avastin, but again, having a very low threshold, because I use treat and extend, I want the drug that will dry them up the fastest and the best and for the longest period. So I think that I tend to use ranibizumab or aflibercept at a much, greater level. But if I have patients that I start in Avastin, I've extended them out 2.5 months. They're happy, their vision is good, I've never changed them. But if they don't dry up after a couple of treatments, if I don't see a nice response, I'll immediately switch them.
I guess the only other point that there's also the CNV data, which also supports Eylea and ranibizumab, which suggests there's a better effect on the CNV with those agents. And my feeling is that starting out of the block, the reason why I'm less likely now to use Avastin is because having reviewed all of the CNV regression data, I want to see if I can give them the best chance right out of the gate of having a regressed CNV, which may not need lots of injections.
Well, the other thing you can do, though, Carl, is bring them back in 2 weeks and do what Phil's doing, and where you treat them very aggressively in the first month or 2 months to try to get a better result. And there are times when I've actually brought them back to see what kind of response and have re-injected them with a different agent.
Right, and I'm starting to do more aggressive therapy right off the bat, typically
Right.
of that approach, because there's no data to support this, but the sense that if you can get this momentum going right out of the block, it might allow you to then further down the road need less injections. I'm willing to try anything to get them on a schedule which down the road they need less injections.
So Jeff, when you say you treat either Lucentis or Eylea, you have to put one above the other. What data, we have a lot of data out there now, what would suggest one to be better than the other in terms of treatment?
So again, I think this is a comparison of degrees. I think they're both outstanding drugs. They've shown that they both do a better job in drying up the retina than bevacizumab. The VIEW data suggests that aflibercept may actually dry it out even more than ranibizumab. So patients were more likely to be dry at a year. As David said, if you looked at the 2 milligram dosages versus the 0.5 ranibizumab, they were almost 50 or 30% more likely at any one point in time to be dry. Again, whether that corresponds to vision down the road, we don't know. It hasn't so far. They've both done a good job. But if you follow the data from VIEW, aflibercept looks like it dries them out a little better. There, as I'm sure you're going to get to, is what do we do with patients who don't seem to respond very well, these suboptimal responders. And we've converted, when we had it with Avastin, our standard low threshold for switching to ranibizumab, we all do that. And I think we've all seen a number of cases where they seem to respond better to ranibizumab than bevacizumab. Similarly, we've had this large batch of suboptimal responders that we've all accumulated over the last 6 and 7 years, and we switched them to aflibercept starting in November when it was approved. And we, again, one of my partners presented our data. We had roughly 150 patients who met that criteria, and we treated them with aflibercept, and after a single injection, roughly 75% had a significant anatomic response. Again, the visual response was small. There was a trend towards improvement, but it wasn't statistically significant. But the mean number of injections prior to the switch was 15. So now, in a year, we may start accumulating aflibercept patients that are suboptimal responders, and we'll treat with ranibizumab. But there is data to suggest from VIEW. There's the modeling done by Michael Stewart and Phil Rosenfeld. There is data out there to suggest that aflibercept may have an advantage in these patients. And finally, the hard-to-treat patients who we show if you needed more injections, you tended to do better with aflibercept. So that all supports that.